Bismillah ar-Rahman ar-Rahim. Hi dear students, we will talk today about DKA, which is a very important subject. It is one of the acute emergency and we will face it a lot in the casualty, in the wards, and the medical wards. Of course, it is a major life-threatening complication, usually occurs in diabetic patient of type 1 diabetes, and it is not uncommon in patient with type 2 diabetes. So it is an emergency and require intensive care unit admission. By definition, it is a state of absolute or relative insulin deficiency and result from hyperglycemia. There is hyperglycemia, there is metabolic acidosis because of accumulation of ketones. And here we have a question. Does it occur as a first presentation of diabetes mellitus? Yes, in about 25 to 40% of patients, they are presented as a first manifestation of diabetes with a DKA. So also it may occur in patients with all diabetes, and they have the presentation of vomiting, dehydration, shortness of breath, abdominal pain, and alteration of level of consciousness. And as we know, sometimes we miss a patient of diabetes with DKA as they have some symptoms which they are similar to flu in diabetic and non-diabetic patients. What are the laboratory findings? In addition to the clinical manifestation, there is hyperglycemia, blood glucose is more than 250 milligram percent, and there is acidosis, pH is less than 7.3, and the bicarbonate less than 20. And also there is ketones in the blood and in the urine. So what's the pathophysiology here? We have to talk about physiology first. Normally the glucose metabolism and the lipid metabolism is regulated by insulin hormone, which is pancreatic hormone released from the beta cell. And there is a counter-regulatory hormone. They antagonize the insulin action. They are the glucagon, growth hormone, catecholamine, and cortisol. So to develop DKA, there is usually we have to think about both have to occur together. The relative deficiency of insulin and there is relative overactivity of counter-regulatory hormone. As you know, insulin is anabolic. It is important for energy substrate production from the storage of glycogen, and there is protein formation and fat storage in the form of triglyceride. And the counter-regulatory hormone, they are catabolic. They catalyze the glycogen and forming glucose and the proteolysis, and there is lipolysis and the free fatty acid production with the ketone bodies. So as we said, there is a normal regulatory hormones. There is insulin and the counter-regulatory hormone which antagonize it. So whenever there is a glycogen breakdown, there is overproduction of glucose. We call this process glycogenolysis. And at the same time, protein, when it is catabolized from another, it will be converted to glucose again, and this we call the gluconeogenesis. And ketogenesis is the breakdown of fat. So in all of these together, they give the picture of DKA. And as we said, we have deficiency of insulin and overactivity of the counter-regulatory hormones. And this is, you have to know what's the ketone. What does it mean? Ketone in the liver, metabolism of the free fatty acid occur in the alternative pathway. There is a beta oxidation, and this will end with a ketogenesis and the result of production of ketones in the blood and as well as in the urine. So the ketone include 3 types: acetone, acetoacetate, and the beta hydroxybutyrate. Pathophysiology of the DKA: whenever there is severe insulinopenia and lack of effective insulin action, it results in physiological cascade of events. There are 3 pathways. First of all, there is excessive glucose production and reduced glucose utilization. So there is hyperglycemia, and this will induce osmotic diuresis and loss of a fluid electrolyte, and this will lead to dehydration, and the dehydration and the reduction and the shrinkage of intravascular compartment lead to activation of renin-angiotensin-aldosterone system, and then it will increase production of the aldosterone, which cause accelerated potassium loss. This is number 1. Number 2, there is an increased catabolic state and there is loss of sodium, potassium, and phosphate by the urine. And number 3, there is increased release of a free fatty acid from the peripheral fat store, and they will end with a ketone bodies production and accumulation, and at the same time buffer system are depleted. So this is a summary. We have inadequate insulin secretion causes hyperglycemia from the increased gluconeogenesis, glycogenolysis, and decreased peripheral uptake. So this hyperglycemia induces osmotic diuresis and causes dehydration, and osmotic diuresis causes renal loss of sodium, and the dehydration causes an increased lactate production because of poor cellular tissue perfusion. And at the same time here we have an increased free fatty acid oxidation. It is an alternative pathway for fuel production and end with a ketone body formation, and this will end with acidosis, and the acidosis causes renal phosphate loss, and there is hyperkalemia with renal potassium loss, as well as vomiting and increased insensible fluid loss, which is again causes dehydration and increased lactic acid formation, and this lactic acid formation will causes acidosis. So as we said, it is the same metabolic acidosis. If we want to know why it occurs, because of accumulation of the organic acid and ketonemia, and at the same time the buffer system will be exhausted, and we have ketonuria. When there is exhaustion of the buffer system, it will be secreted through the kidney. And here we have to check the pH and the bicarbonate level. As a compensatory mechanism, there is type of rapid shallow breathing, we call this plasmal respiration, to overcome this acidosis. The ketones, as we said, particularly there is beta hydroxylate, which causes nausea and vomiting in these patients. And acetone also produces a fruity breath odor in ketotic patient. It is a special odor. As we said, hyperglycemia, when it is exceed the renal threshold, which is 180 milligram per deciliter, there is glycosuria and osmotic diuresis, and will end with severe dehydration, thirst, and hypoperfusion in the tissue, and there is lactic acidosis. As we said again, hyperglycemia causes osmotic diuresis, and there is serum hyperosmolarity. The same, we have to think about hyperosmolarity, osmotic diuresis, hyperglycemia, and metabolic acidosis. All these together result in severe electrolyte disturbance, which is common in patients with DKA and might be very risky, because one of them is hypokalemia. One of them, as we said, hypokalemia, hyponatremia. Hypokalemia especially causes mortality. The most characteristic, as we said, is hypokalemia. And we have to check potassium level. It is an intracellular ion. So when we measure the potassium in the blood, usually it reflects the extracellular part, not the intracellular part. Here, the urinary loss of potassium occurs because of the shift of the potassium from intracellular compartment to the extracellular compartment because of acidosis, which aggravate the shift from intra to extracellular compartment. And also potassium loss occur again due to osmotic diuresis, and it will be excreted through the urine, and also to the we said the calorific effect of the hyperaldosteronism, and this is because of dehydration. So potassium, is it low in patient with DKA or normal or high? Usually they are normal. Even when the total body potassium depleted, it will be normal because of the shift from intracellular to extracellular. And as we said, the part that we tested in the lab, it is the extracellular compartment, not the intracellular. So there is really intracellular hypokalemia, but extracellular it is normal. So as we said, why there is loss? Because of acidosis, and here the extracellular compartment, it contains a high amount of hydrogen ion, and the potassium will shift from the intracellular to extracellular for exchange with this hydrogen ion in high concentration, and a large part of this shift is lost in urine, and because of osmotic diuresis ended with hypokalemia. So this is the pathophysiology. What about sodium? Sodium will be low. And why it is low? For several reasons, including there is depletion due to urinary loss because of vomiting, and factitiously lower serum volume because of hyperlipidemia displays sodium in the most frequently lab. So it is something as a lab error, and there is a hyperglycemia which causes high osmolarity, and water will be driven to the from the intra to extracellular space, and there is dilutional hyponatremia. So clinically and practically, usually it is dilutional type of hyponatremia. Most commonly it is dilutional type. So we have to remember that for each 100 milligram percent increase in glucose, serum glucose above 100 milligram, there is an expected decrease of about 1.6 milliequivalent per liter in measured sodium. So suppose the blood sugar is 300. We have 200 milligrams exceeding the 100, the first 100. So what we expect? 1.2 for each 100, so multiply by 2, it will be 3.2 milliequivalent per liter increment in the amount of sodium. And we have a formula to be calculated. Sodium plus glucose minus 100 multiplied by 1.6 over 100. This is the correctable sodium. And we have to remember that when we correct DKA in the patient by giving fluid, by giving insulin, so there should be the increase of sodium will be 1.6 millimole for each 100 milligram per deciliter decline in glucose. So this is the reverse. Should be increased as the glucose decreased. So if we have the corrected value of sodium is more than 150 millimole per liter, so we have hypernatremic dehydration, and we have to start a slower fluid replacement. As well as when there is excessive declining of sodium, this indicates excessive water accumulation, and it is a risk for cerebral edema. So we have to check sodium regularly. These are with prolonged illness and severe DKA, there is body loss of sodium potassium phosphate, and we have to check these measures and these electrolytes every 4 to 6 hours yearly, and maybe later every 12 hours, and so on. And these will be corrected by giving the usual treatment for these electrolytes. We have to remember that when we correct the sodium deficit, and it can be repaired within 24 hours, we have to remember that potassium and phosphate, they are not completely restored for several days. And we have to remember that the combined effect of hyperosmolarity, dehydration, and acidosis, they result in increased osmolarity of the brain, and this will end with altered consciousness. So what's the clinical feature? There is, of course, risk factor for DKA precipitated by intercurrent illness, by trauma, by infection. So what are the symptoms? They got nausea, vomiting, polyuria, polydipsia, nocturia, abdominal pain, shortness of breath, and weakness, sometimes missed the case as gastroenteritis, or sometimes missed as a case of a flu. What are the signs? There is dehydration, hypotension, tachycardia, tachypnea, calcium respiration, acetone odor of breath, abdominal tenderness, and lethargy with altered level of consciousness, and possibly there is coma. We have to do certain investigation, like we have to send for blood glucose, and serum glucose will be more than 250 milligram, and the bicarbonate is low, less than 20 millimole per liter. Arterial pH is less than 7.3 depending on severity, maybe less than 7, maybe less than 7.2, and it depends on the severity. Anion gap is more than 12 to 16, is more than 16, and we have the urine analysis. Usually there is ketonuria and glucoseuria, and we may send for additional tests. Here we have amylase. Serum amylase will be high. If lipase is high, it means it is non-specific, maybe salivary gland involvement. It is not specific for the pancreas. And we have to check the serum creatinine also, because it might be falsely elevated depending on the interference by the ketones in autoanalyzer methodology. So it does not indicate certain pathology if it is an increased serum creatinine. Maybe it is pseudo-positive. Blood urea nitrogen also elevated because of dehydration, and we have to check for infectious etiology. We have to send for CSF if there is sign of encephalitis or meningitis, and chest x-ray if there is infection. Urine, maybe urine analysis, general urine or culture, and so on. And we have to recheck the patient for evidence of rehydration, and we have to check the weight. First of all, we have to check of the weight to assess the amount of dehydration, and later to have to check for the inappropriate secretion of antidiuretic hormone and possibility of cerebral edema. And there is importance of the cardiac monitoring for T-wave for if there is change like in hypokalemia. We have to do ECG and regular monitoring. Despite total potassium deficit, the serum potassium at presentation may be mildly elevated secondary to acidosis. And we have to check the total body store of sodium chloride phosphate and magnesium. They are reduced in DKA but not accurately reflected their level in the serum because of dehydration and hyperglycemia. And elevated blood urea nitrogen and, as we said, creatinine level reflect intravascular volume depletion. So how we manage patient with DKA? First of all, what our aim in the management? We aim to restore the normal hemodynamic status and correct dehydration, and we have to restore the normal acid-base balance and to correct blood glucose level. First of all, we have to restore perfusion by giving fluid, and this will restore the glomerular filtration rate and reverse the acidosis. And we have to give insulin to stop ketogenesis, and this will reverse proteolysis and the lipolysis, and also to reverse acidosis. And we have to correct electrolyte by giving the electrolyte deficit and by giving further supplementation. We have also to avoid complication during therapy like intracerebral complication and cerebral edema or hypoglycemia, and we have hypokalemia as a complication. So treatment, first of all, we obtain and monitor vital signs and including blood pressure, pulse rate, respiratory rate, temperature. And we have to check glucose determination every hour or every half to 1 hour interval and assess the state of hydration and mental state. And we have to send urine, as we said, for glucose and acetone and ketones, and continue to monitor the urine every void. Then we have to draw blood for electrolyte, blood urine nitrogen, venous pH, complete blood count. The treatment in the first hour, we start with hydration. We have to put 2 IV lines, and we have to infuse 20 cc per kg of normal saline over 30 to 60 minutes. And be cautious not to give bicarbonate therapy because it is might predispose to cerebral edema. And we have to consult pediatric endocrinologist, and we have to check for the intensive care unit. So we have to start again, in addition to fluid, after first hour of resuscitation by giving fluid, we have to give insulin drip of regular insulin, dose of 0.05 to 0.1 unit per kg per hour. And insulin should be given in the beginning of treatment because it accelerates the movement of glucose intracellularly and decrease the hepatic glucose production, and also it stops the movement of fatty acid from periphery to liver and decrease ketone production. So initial insulin bolus does not speed recovery, and that's why we have to use infusion. On the contrary, bolus might increase hypoglycemia and hypokalemia. So we start infusion without bolus. And the infusion, as we said, should not be stopped. Even if the patient glucose level declining, we have to decline the dose to 0.05 unit per kg per hour to prevent recurrence of ketosis. And we have not to discontinue infusion until the subcutaneous insulin have been given and when the child returned or recovered and after he start oral feeding. We have to remember that if the blood glucose falls below 120 milligram per deciliter, that is 7 millimole per liter, we have to increase the concentration on infused glucose to prevent hypoglycemia, not only normal saline. We have to give, in addition to the normal saline, we have to give glucose. Ketosis also clear more quickly if insulin infusion given prolonged for 36 hours. That's why we prefer to give infusion and for long period and not to stop it immediately. We have to start with a subcutaneous injection while we are decreasing the dose of insulin. In the second hour after resuscitation, slowly correct the fluid deficit over 48 hours by giving normal maintenance of fluid together with a calculated deficit. How we calculate fluid deficit. First, by weight loss or by clinical assessment. And if the patient has severe dehydration, maximum is 8.5% of body weight decline. So multiply this 8.5 by 100, it will equals to the calculated deficit, 100 ml. Okay, and the calculation of maintenance fluid per 24 hour. For each kilogram in the first 10 kilograms of the body weight, we have to add 100 cc per kg. For the next 10 of body weight, from 11 kilogram up to 19 kilograms, we have to add 50 cc for each kilogram above the 10, the first 10. And for each kilogram above 20, we have to add above 20 kilogram, we have to add another 20 cc per kg. So for example, if we have a child of 25 kilograms, he would receive for maintenance, as we said, for the first kilograms, it is 10 per kilogram, so it is 1000. For the next 10 kilograms, it is 50 cc per kilogram, so it is the total is 500 cc. And for the third 10 kilograms, we have to add 20 cc for each kilogram. As he have only 5 in the third kilograms, and the third 10 kilograms above 20, so we have to add only 20 cc per kilogram, so it is equals to 100, and the total dose is 160,000 cc per day or 67 cc per hour. And we have to give the replacement or the deficit if it is 100%, if it is 10% dehydration, so it will be 2,500. And we have to give isotonic fluid until the blood glucose fall into 250, so we have to give normal saline. And we have then to add glucose, either we may add when the blood glucose reach 250 or 300, we have to add to the normal saline glucose water, either 5% glucose water with normal saline, which is 0.9 saline, or 5% glucose with 0.45% saline. And we have to continue the maintenance with dextrose saline until the child eating and drinking normally. So what type of a fluid of distilled water or we have to add? We have to add 5% distilled water when the blood glucose 250 to 300, and we have to add distilled water of 10% when the blood glucose 180 to 200. Our target here to decrease the level of glucose 80 to 100 milligram per dc per liter. It is not more. So rehydration, of course, it will lower the glucose level, and at the same time it improves renal perfusion and renal excretion. And we have to remember that once the glucose reach 180 milligram per deciliter, osmotic diuresis is stopped and the correction of rehydration is better and faster. What happened if cerebral edema occurs? Sometimes it occurs, and we have to restrict fluid replacement to 2/3 of total. If it was, suppose it is 3,000, we have to decrease to only 2,000 cc per 24 hours. And it is not only decrease the amount to 2/3, we have to elongate the period of replacement from 24 hours to 48 hours or maybe longer. And we have to check the fluid balance. And of course there is ongoing loss. Ongoing loss means the fluid that lost with respiration, with perspiration. They should not worry about this. It is not normally required. This is the flow chart for a patient admitted to intensive care unit or even the ward and pediatric ward with DKA. We have to take in consideration the date and time, mental state, blood pressure, pulse, glucose, sodium chloride, potassium, bicarbonate, etc. And we have to check the ketone in body and the IV fluid, type of fluid, the amount and insulin dose, and also the urine output. So the input and output is important here. About potassium supplement, we have to add potassium to every patient with DKA. After the serum plasma level, if it is below 5, we have to add potassium, or if there is good renal output. And usually it is started after 1 hour of resuscitation with the fluid. And we have to put potassium for each fluid then. Each pint given then should be added we have to add potassium. So amount of potassium add, it is a 3 to 5 milliequivalent per kg per 24 hours. Usually we give potassium chloride, but if we use potassium phosphate, it is not a standard and we have to use only half correction. So half the dose should be given if it is potassium phosphate, because it might induce hypocalcemia and tetany. Okay, this is the amount of potassium given for each level of the serum potassium level. What about bicarbonate? Metabolic acidosis occur sometimes it is severe, but there is no need to give IV sodium bicarbonate to correct acidosis. It might cause harmful effect, but it might precipitate cerebral edema. And we have to remember that failure of correction of acidosis, because maybe due to inadequate fluid or inadequate insulin replacement, or maybe due to gram-negative infection, we have to search for these and we have to correct these. Sometimes we have mistake in correction of a fluid or estimation of a fluid. We have to correct, and acidosis will be improved gradually. And the only justification for using IV bicarbonate in acidosis when there is severe acidosis and compromised cardiac contractility, usually if it is less than 7.1. Other electrolyte, no need to compensate. It will be compensated by its own. And this is a table shows the management or protocol of DKA. As we said here, in the first hour we have to add this type of fluid, 10 to 20 of normal saline bolus or ringer, and we have to use the insulin drip in the first hour, and we have to check for possibility of cerebral edema, and we have to push mannitol if there is cerebral edema evidence. In the second hour we have to change the fluid from normal saline to half strength normal saline, and we may add glucose, 5% glucose if the sugar declining below 250 milligram per deciliter, and potassium phosphate and potassium acetate or chloride may be added. Here the fluid collected in the first hour, we know there is a shoot of normal saline. In the second hour, IV rate should be estimated as 85 ml per kg plus the maintenance minus the bolus. Bolus, that is the fluid giving in the first hour, should be omitted, and this is divided on 23 hours because the first hour is elapsed already. And we may add, as we said, if there is hypokalemia, we have to give oral sodium or increase the fluid amount of potassium given to 80 milliequivalent per liter. If the patient improved after the first 24 hours, or maybe extended if there is evidence of early cerebral edema, we have to extend the period to 48 hours. Then we have to start the oral intake, and we have to give subcutaneous insulin. And if there is no emesis also, and the CO2 will be more than 16 and normal electrolyte, so the patient will pass to the second stage. It is not in ketoacidosis. Here the ketones may be still predominate, but it will disappear within a few days. So we have to know that the maintenance, how we calculate the deficit and how we calculate the maintenance, and this is the formula used, and this is an example. So amount of insulin given, this is diabetic ketoacidosis in the prepubertal, pubertal and postpubertal. It is equal to 0.75 per 1 unit per kg, and in diabetic ketoacidosis in the pubertal it is 1 to 1.2 if it is pubertal, and postpubertal if the patient is postpubertal age, we have to give 0.8 to 1 unit per kg. Lab parameters, blood sugar hourly should be checked then, and it is as required, and electrolyte every 4 to 6 hours, and then as required. And we have to remember that DKA, it causes morbidity and mortality, and maybe primarily due to cerebral edema, which is equals to 1 to 5% of DKA episode, and this is the gravest complication. When it occurs, usually it occurs within 6 to 12 hours after initiation of treatment and partial improvement. We have to remember that with the rehydration, we have to check the accurate index of tonicity, which means we have to check the effective serum osmolarity. It is equal to 2 multiplied by the sodium, which is uncorrected, and glucose. And this reflects the tonicity of the serum rather than other way of estimation. And we have to remember that if it is hypertonic, we have to do the replacement of a fluid very slowly within 48 hours. And we have to remember that if the tone of this index of tonicity of the serum osmolarity is low, meaning there is possibility of cerebral edema. What are the complications of DKA? Dehydration, shock, hypotension. Also we have hypokalemia or hyperkalemia, hypoglycemia, aspiration pneumonia, sepsis, acute tubular necrosis, myocardial infarction, stroke, and cerebral edema. What about cerebral edema? As we said, it is occur in 1 to 5% of cases. There is high mortality and even neurological morbidity. The pathogenesis is not well understood, and sometimes it is attributed to a cellular swelling, the result of rapid osmolar changes in some studies and during intravenous infusion. Sometimes maybe not related even to the sodium content of infusion and the volume of infusion and the rate of serum changes in the serum glucose concentration. So these studies suggest that there are other factors important in pathophysiology of DKA related cerebral edema rather than the fluid and the amount of concentration. So what are the clinical features? There is decreased sensorium, sudden or severe headache, incontinence, persistent vomiting, disorientation, agitation, ophthalmoplegia, pupillary changes, papilledema, and posturing seizures. So we have warning signs. As we said, the most important is headache, incontinence, seizure, pupillary changes, decreasing heart rate, increasing blood pressure, which means there is an increased intraventricular pressure. What are the risk factors? If we have the first PCO2 level is low, the initial PCO2 level is low, and when there is initial blood urea nitrogen when it is high, and there is lesser increase in sodium with therapy and treatment with bicarbonate. These are the risk factors. How we treat cerebral edema? First, we have to urgent recognition. We have to diagnose the case earlier, and the treatment here is essential. We have to treat with mannitol, which is an osmotic diuretic, and we have to use a 3% hypertonic, either mannitol or hypertonic, and followed by CT scan. We have to refer the patient to the neurosurgeon and reduce IV fluid, as we said, to 2/3 of maintenance or 70% of maintenance. We have to elevate the head to 40 degree, head of the patient or the bed of the patient to 40 degree, and we have to do consider intubation and controlled hyperventilation. And we have to check the intracranial pressure monitoring repeatedly, and this will improve the outcome. How we treat? By giving mannitol. The dose of mannitol here 0.5 to 1 gram per kg infused over 30 minutes, and we may repeat it after 1 hour. Or we may use, as we said, hypertonic saline in 5 to 10 ml per kg and given over infusion over 30 minutes, and we may repeat it 1 hour later. Only 1/2 of children who develop cerebral edema have obvious sign of deterioration. Most of them, they are subclinical, and sometimes they present with the respiratory arrest. And we have to, younger children have a greater risk of this respiratory arrest. Also, we have to remember that in United Kingdom study reported that every child who presented with respiratory arrest either died or was left with a neurological deficit. So prevention is better than cure. This is to summarize the case. If there is hyperglycemia and increased osmolarity, and there is intracellular dehydration, osmotic diuresis, and will end with azotemia, acidosis, and hyperglycemia. This is the pathophysiology, and this is a treatment protocol, Milwaukee DKA protocol. As I add this table to remember you, in the first hour we have to add fluid, just the fluid and insulin, and in the second hour we have to remember that we may add the glucose here, as it is decreased less than 250 the concentration of the glucose. And after 24 hours, most of the patients, they take oral feeding and subcutaneous insulin, and some of them, when there is hyperglycemia, we have to, and hyperosmolarity, when there is hyperosmolarity, we have to continue the treatment for 48 hours. And this is the infusion rate. It is 85 ml per kg plus the maintenance and minus the bolus dose. And we have to remember we are using this for the next 23 hours. And this is the same as we said. We have to start with isotonic fluid, and the next hour we have to add hypotonic, which is half strength normal saline in addition to glucose. and this will rehydrate the intercellular compartment, not only the intravascular space. Thank you very much.